Dr. Tan Meng.
Mr. Speaker, I declare that I'm a medical doctor in a public hospital looking after cancer patients. It's been 57 years since independence, 6 decades since MOH was set up during British colonial times, nearly a lifetime. So we should take stock, ask ourselves, not just what comes next, but what if? What if we reimagined our healthcare system today anew? What would we keep? What would we change? What would we transform? Healthier SG is an important first step in this reimagining. It is an opportunity for a healthcare transformation, and I dare say, a healthcare revolution. Earlier this year, during the debate on MOH's budget, I called for change, a change agenda. Today, speaking on Healthier SG, I will speak on helping residents and helping family doctors to help residents. Let me start on co-payment. It was a central dogma for public healthcare financing in Singapore for many years. But we must judge policy not based on dogma, but whether it gets the job done, whether it achieves the desired goals. The original idea for co-payment was to shape behavior so that people look at the bill, consider what's value for money. But what happens if co-payment discourages some residents from going for medically recommended screenings, medically recommended vaccinations, medically recommended treatments for chronic disease, even if the illness might become a bigger problem some years down the line and cause suffering that you cannot even put a price tag on? The less well-off might well be affected the most. So it's an important step to fully subsidize nationally recommended screenings, vaccinations for Singaporeans, to remove the need for cash co-payment when using MediSave to treat chronic disease under the care of a family doctor as part of an MOH program. In short, the behavioral nudge needs to be towards prevention and health, rather than sludge that makes it harder to do what is necessary to prevent greater problems down the road. We should make it as easy as possible for people to do the right thing. Nudge, not sludge. Sir, on subsidy, the place of subsidy matters too. In our early days with a young population, subsidy was very much centered on the acute hospitals. Over the years, subsidy has become more and more decentralized so that care can be delivered with subsidy in the community for chronic illness closer to home. But with our aging population, with seniors becoming less mobile, some finding it harder to go out, we also need to look at how care and, where needed, subsidy is delivered to patients and residents in the community, seeing through the eyes of our people. Sir, I visited the funeral wake of my Clementi resident, spoke with a family who told me their story. Amma had been ill for some years, ill with a major stroke, bedbound, couldn't get out of the house. She was a pioneer generation Singaporean, pioneer generation card. But because she was not mobile, bedbound, she physically could not get to the polyclinic near the home. That meant she couldn't access the polyclinic care without a means test. It meant she could not apply her pioneer generation card subsidies towards the remainder of the bill without having to go through a means test. In contrast to an able-bodied Singaporean able to go to a polyclinic, walk in the door, access polyclinic care without means testing, apply the PG card without means testing. The family engaged a home doctor from an established VWO, house calls, writing medicine prescriptions on a piece of paper, a paper prescription, The family would then bring the paper prescription to the nearby polyclinic and pay unsubsidized rates for the medication. Now, had Amma been physically mobile, able to get to the polyclinic in person, there would have been no such administrative hurdle. So we need to look at cases like this, see if there are ways to deliver care closer to patients' homes and even have some medically necessary consultations in patients' homes if needed. And likewise, to see if the funding journey can be more straightforward for such home medical visits where they are assessed to be medically necessary. There are also some Clementi seniors who have regular medical appointments at hospitals needing blood tests. They are wondering if some of these medically necessary tests can be done closer to home or on occasion at the home while still receiving some level of subsidy. It saves time waiting for some blood tests that may take several hours, and it saves a trip back and forth for blood tests that need to be done a few days before the medical appointment. Because when a caregiver has to accompany a patient back and forth, the burden, the stress, the worry doesn't just fall on the patient. It falls on the caregiver who may have to take time out from work, and often it is the less well-off caregivers who have less bargaining power with an employer, less able to take time off without worrying for the safety of their jobs. So for medically necessary treatments, Mr. Speaker, we should look at how to bring the subsidy to the patient, if it helps prevent hospitalizations, reduce the burden of suffering, if it reduces the number of visits and the load on caregivers. Because when subsidy is tied to a physical venue, a place of bricks and mortar, it can become accidentally regressive, because the less well-off patients and families who are less mobile, they find it harder to get to the place of care, harder to access to the subsidy, and it is these families who also find it harder to apply for private medical transport to foot the bill to get to the place of care. So I call upon MOH to look closely at this, because if the policy intent is to provide subsidy where help is needed, then we have to keep a lookout for physical or systemic barriers. There's a broader point, Mr. Speaker. How do we better support residents and particularly long-term patients who continue living in the community and want to minimize visits to and from hospitals? Patients with advanced neurological conditions like motor neuron disease. I asked the PQ in Parliament yesterday, but unfortunately, time ran out and I couldn't ask my supplementary question. So patients with advanced neurological conditions, later stage kidney diseases or dementia. Can we find ways to better empower family doctors who have known these patients for years, family doctors who hope for better support from the hospital clusters to care for patients in the community? So I call upon MOH to look at forming a work group as part of Healthier SG, to look at the issues faced by long-term patients with serious medical conditions living in the community. Look more closely at patient journeys, deeper at the challenges faced by caregivers, healthcare providers, seeing through the eyes of our people. Sir, I want to talk about Healthy 365. MOH has designated the Healthy 365 app as the digital window to programs by PA, HPB, Sport SG, and other programs as well. But what happens for seniors who don't have a smartphone, who are not digitally savvy, who aren't quite comfortable using a smartphone app? We must make sure the digital window does not become a digital bottleneck. There must be careful attention to ease of use, understanding what our seniors and elderly need and find easy to use. Technology must serve, adapt, and bend to the person, rather than getting people to bend to the technology. Seniors who feel left behind by digital change should not be treated as having fallen by the wayside or not able to adapt. Just because a senior isn't on a digital dashboard doesn't mean the senior is not there. Sir, Healthier SG also mentions residents having individual choice of healthcare provider. This must be in practice, not just in theory, I've met Clementi residents asking what will happen at our national specialist centers that treat heart disease or cancer, for example. A cancer patient may have lived in Tiong Bahru for many years, but chooses to stay with a loved one in Jurong who can be caregiver while they undergo treatment. So she might want to see a specialist in the West rather than in central Singapore. Some Clementi residents have asked, will it become harder to seek specialist care in a hospital outside your own geographical cluster? Will there be obstacles to patients choosing which public hospital they can go to receive their subsidized specialist care once capitation kicks in? Can MOH confirm that patients will not face uphill hurdles, financial or administrative, if they wish to see a specialist at a different public hospital from the healthier SG cluster near their home? Sir, let me speak on helping family doctors to help patients and residents. I want to talk about care and how it takes time. Preventive care, chronic care, holistic care, it takes time. Some of these discussions are as much conversation as consultation. Talking with a patient that you've gotten to know over the years, understanding why they took up smoking, why it's hard to kick the habit, persuading them to make that change for better health and to save their life. Talking with a senior who's just been discharged from hospital after an illness, helping that senior find hope and confidence again to go back to exercising and leading a healthy lifestyle. Or making that time to be with a patient and a family through a difficult illness that may be getting worse, working through with the patient and family what might be best in the difficult months and weeks or even days ahead. All this takes time. And so it's so important for MOH to continue looking at what happens in the real world, understand how much time is needed to deliver holistic care, and to support our healthcare workers and family doctors on that journey. Paying family doctors to do this important work, recognizing the time needed, it's an important step. It sends a message that the work must be done, is being done, and needs to be recognized. Will MOH also apply these important lessons to our public healthcare system too, so that our polyclinic doctors and healthcare workers can also be given more time, space, and support to deliver that holistic, preventive, well-rounded care that we continue to work on and aspire to? I want to speak on enablers. The Healthier SG White Paper mentions system enablers. We enable by making systems better. But this must also mean easier access, easier to navigate, fewer obstacles. I want to talk about medical IT, Mr. Speaker. Earlier this year, I spoke on how across the public healthcare system alone, we have 14 million consultations each year. Imagine if we saved 1 minute on waiting for computers and apps and technology-related time spent, less time spent waiting for technology or grappling with technology. That would mean 14 million minutes saved every year. 10,000 work days, or about 27 years of someone working 24 hours a day. It's not a small matter. And with more family doctors coming on board, connecting with the public sector IT system, it's all the more important that the IT continues to improve, enabling, empowering, not getting in the way. Even as healthcare IT is enhanced, there must be attention to ease of use. Sometimes people prefer paper records, manual processes, not because they're afraid of technology, but because they find that existing technology platforms are more cumbersome, take more time. And in our design and implementation, we must continue looking at this. I previously called upon MOH to give this the same attention and focus as the big firms do, like Apple and Google, because today, every patient, every healthcare practitioner knows how a well-designed IT platform from a major tech firm can do things. And people will benchmark ease of use, elegance, against what the big firms do as well. Mr. Speaker, some healthcare workers and family doctors worry about the paperwork and administrative overheads from Healthier SG. The white paper mentions submission of patient data. Will MOH look at how the software is designed, how long it takes to fill up a form, whether existing clinic software may become slower or more cumbersome once it connects with the public sector IT network? Has MOH assessed whether small clinics will need additional headcount to address the compliance requirements of joining Healthier SG? Will the subvention consider this as well? On capitation, Mr. Speaker, MOH has said there'll be a shift to capitation funding, where clusters get a predetermined fee for every resident assigned within a geographical area. Can I ask the ministry, will capitation consider that different patients have different needs? Some patients having more medical conditions, more illnesses, more complex needs, and thereby more attention and more funding needed to achieve the same healthcare outcome. Sir, systems and enablers in the healthcare process, it depends ultimately on our workforce, our people. Our people are what enable us to deliver care. Healthier SG means that the role of family doctors in the community will be ever more critical. Doctors drawn from the community, serving, caring, looking after the community. So we need to ensure a diversity of backgrounds and journeys in our healthcare workforce, in our medical profession, at every level and in every generation. Much work has been done. There has been progress, but we must continue giving this much deliberate attention. Whether it's flexible work arrangements so that healthcare workers who are parents, who are caregivers to an elderly relative, who need more flexible arrangements at work, that they can continue training, developing, growing, progressing on their journey. Likewise, also going upstream to ensure that no matter where you start in life, no matter your background, no matter whether your journey took longer or a detour, that your starting point never deters you from stepping forward on that journey. Mr. Speaker, in conclusion, as I said 2 years ago during the debate on the President's address, healthcare is about all our lives, your life and mine, the lives of our loved ones, the life of every Singaporean. I call upon the Ministry of Health and this government to provide the resources, energy, and imagination to do what is necessary to keep our healthcare system fit for purpose today, for tomorrow, and for a generation to come. I stand in support of this motion.